Hello everyone and welcome to the 2025 Brain Injury Awareness Week event. I'm Melissa Hartman, your host for today's event. I can't wait to share this special day with you all. Before we get underway, please join me in welcoming Robert Taylor, who will be performing the Welcome to Country. Thanks, Robert.
Good morning, ladies and gentlemen. How are we all feeling this morning? Good, yeah? I'm an Aboriginal man. I like to use the word deadly. Can you fellas say deadly? Deadly. I use that word but in a non-venomous way, all right? So if you ever do wonder what that word means, it means very, very good or excellent or great or better than very good, all right? So that's the context, I guess, of it. So my name's Robert Taylor. I've seen many of you here before. This is I think my second, maybe my third year being a part of this event, and it's a pleasure to be here, to stand alongside you today as we together acknowledge this beautiful place that we're gathered on as Kaurna country and also the traditional land of the Kaurna people. So I'm a senior Kaurna man. I take the title of senior Kaurna man. I'm not really ready for elder status yet, I guess. I still follow in the footsteps of many elders that are still around us and are still sharing their knowledge with us here in the community. It's Aboriginal way that when we introduce ourselves, we always mention the groups that we come from. So I come from 4 groups down here in this part of the land. The Ngarrindjeri people from the lower parts of the River Murray and the Coorong, or traditionally known as the Kurunk. The Nangaraku from around West Swan Reach and Manamis, also along the River Murray. The Narungga people from the York Peninsula, Ajadura country, the land of the butterfish. And the Ghana people from this wonderful city we now call Adelaide. Yeah? It's a funny word, that one, isn't it? Adelaide, Adelaide, Adelaide. I think many of you know it's been called Adelaide for about 45 seconds in the course of history. You may have heard the traditional term before as Taranda Nyanga, yeah? So Taranda is the big red kangaroo. The NGGA on the end, the Nyanga part, is just a suffix, meaning we're in, on, or at that place, yeah? My elders always said to me, they said, nephew, this place is Taranda Ganya. So Taranda, the big red kangaroo, and Ganya means rock, yeah? So if we put the NGGA on the end of that, being in that rocky place of the big red kangaroo, it becomes Taranda Ganyananga. So it's a bit more there, and there is actually a sign up at Victoria Square that says Taranda Nyanga, and if I did have that chat with Mr. Malinakis about it being Taranda Ganyananga, I don't think they'll have enough room on that signpost up there to put that language up there. So in the spirit, I guess, of Ghana and my ancestors, I say, Nyankinya Miana Namarni, Mani Nabunin Yadluku Yata, Taranda Ganyananga Gada Wirapari Ghana Yata, Nyanari Robert Kari Karamil Taylor, Naranjiri Nangaraku Naranga Kumagana Mirna. Marni Nadlu Tamperdi Ghana Mirna, Kumanadlu Pana, Itanga and Brendi, Tapandala Bukiana, Burkana, Kumagana Mini Alada, Nayakan and Dalia, Nayungan and Dalia, Na Chalia. Ladies and gentlemen, how'd you go? There's a lot there. Did you understand all that? Did you want me to slow it down for you? I think that's the thing when we speak in our native tongue. It sounds fast, and I'm told that I talk fast, so it's like a chipmunk version, I guess, of when I'm speaking in language. But a basic greeting you may have heard is the terms Nina Mani or Na Mani. They mean the same thing. They mean how are you or are you good. If you're well, you reply with Marni I. Can we try that together? All right. Na Marni. Marni I, very good. So if you do hear somebody greet you in the language of the Ghana people and you do reply with Marni I, please tell them you learnt that from Robert Taylor, all right? Nothing wrong with a bit of healthy competition, yeah? We don't actually have a word in our language for that means welcome, but we do have a terminology that we use for it, and that's called Mani Nabudni. And it means glad you come, yeah? So when we greet people and we say Mani Nabudni, it's a term that we use for welcome. It's like spirit talk, I guess. When we travel out to different places, as I said, I come from 4 different language groups down here. When I'm travelling out of Adelaide or to Murray Bridge, I see them signs and it says, welcome to Murray Bridge. It's spirit talk. It's saying glad you come. So that's the words that we use when we greet people. So on behalf of my Ghana elders and ancestors, I stand alongside you today and I say, Mani Nabudin Yaluku Yata, Taranda Ganya Nanga Gara Wirapari Ghana Yata. I welcome to this place, the rocky place of the big red kangaroo, along the banks of the Red Gum River, or you may know it as the River Torrens, but Gara Wirapari is its traditional name. Just a little bit of brief history about our river here. It used to be a bit more like a big creek. When the first colonisers arrived here, just prior to 1830s, it was about 1828. This river system, it was a freshwater river system, and it was not as wide as what you see it as today. And there used to be an abundance of wildlife in this area, particularly the big red kangaroo, hence why the place is named after this. But the rocky banks of the river is why we call it the rocky place of the big red kangaroo. There used to be an abundance of platypus down here in this part of the world. A lot of people find that hard to believe. They've lived here for most of their life, and then they look back and they say, did you used to have platypuses down here in this part of the world? And we say, yeah, we did. Unfortunately, to urban expansion, I guess, what happened was people would take the rocks out of the river and they would exchange them for rations, yeah, with the early missionaries. And then they would build some churches with them then, such as the church you see just across the road here, Trinity Church, also the big cathedral down here in North Adelaide. So by taking these rocks away from the river, the river's gotten wider, and also, the platypus used to rear their young in the banks of the river, so we've actually taken that habitat away from them. But it's a mystical place, and it's a wonderful place. The last traditional kangaroo hunt that actually took place here was in 1892, and it was directly where Hindley Street is as we know it today. So maybe think about that on a Friday night or a Saturday morning, you fellas, as you're going down past there. But look, I acknowledge each and every one of you. It's very important. We come together. We do live in a very multicultural, community, a very multicultural society. I feel we live in the best city in the world. There's no nepotism in that whatsoever, you fellas, either. But as I say, we share this land. We are all modern-day caretakers of this land. It's our responsibility to look after one another and also to look after this country as we move into the future and to pass that down to the younger generations. But to leave you with one last blessing, I say, Bukiana Mirna Yancha Yardako Nyadloko Yarananko, Yancha Yarda Tirapanga, Nyadloko Mirna, Tirapanga Kuma. In language, I ask my ancestors to call upon the spirit of your ancestors, and we invite them to come together in the spirit world as we are in the physical, to be here with us, not just today, but into the future, to bless this beautiful place that we all call home, but more importantly, to bless each and every one of you and your families, yeah? I hope you have a wonderful day. Enjoy this spring weather that's coming up, because we've just come through a cold winter, and this is my favourite time of year, ladies and gentlemen. So I hope each and every one of you are embracing it as much as me and my family are. Nachalia, thank you very much.
Thank you, Robert, for that moving welcome. We are so thankful to have you join us again this year. We have a few formalities to get through before we welcome our key speakers for the morning. But first, I'm pleased to introduce myself. For those of you that don't know me or my story begins almost 4 years ago in August 2021, when I was getting ready for a date when I experienced a sudden coughing fit. I disappeared into my room for water and collapsed. Luckily, a good friend of mine was over and heard me collapse. He quickly called an ambulance and then immediately started CPR whilst waiting for the ambulance to arrive. This episode was to be the first of multiple cardiac arrests I would have, and needing my heart to be restarted by a defibrillator 7 times on the way to hospital. When I arrived at the hospital, I was placed into an induced coma for a week, and when I woke, I had no idea where I was. I thought I was late for work, but I soon realised I was having difficulty speaking and that I was in fact in hospital. In September, I received the life-changing diagnosis of a hypoxic brain injury secondary to a sudden cardiac arrest, caused by the lack of oxygen to my brain during these cardiac arrests. While in hospital, I had a pacemaker and a defibrillator inserted into my heart to help regulate my heartbeat. And from then on, I essentially had to relearn how to do so many things again. I spent 6 weeks in Hampstead Brain Injury Unit, which was tough, with one of the biggest challenges I found was being away from my children who I primarily cared for. However, I turned this into my biggest motivation as I was determined to get home to them and be their carer once again. My time in Hampstead was both life-changing in the way that it helped me to get home, but it was also very debilitating. My mental health plummeted here. I was so far away from my kids as well as my family and friends. As a person who was outgoing and social beforehand, spending so much time on my own was really lonely. I would be so happy whenever it was nurses' rounds, but the nurses could only talk for a few minutes, and even then I wasn't able to communicate properly, so by the time I could get my words out, they were off to the next patient. One of the biggest breakthroughs was discovering the power of music. The speechies and OTs discovered that by listening to songs, I was able to piece together memories, and this became my biggest tool in my recovery. After my weeks in Hampstead, I was determinedly walked out the door as I was discharged for home. Being home had its own challenges that I needed to overcome. I no longer had my driver's license, and I struggled with my fatigue and my moods. As my injury had impacted my frontal lobe, I had challenges in concentration, memory, decision-making, fatigue, and sensory overload. I had to relearn how to walk, talk, and navigate everyday life, and then learn to plan and build in my rest to avoid burning out. 4 years on, I've started looking for a job, and I've secured myself a volunteer role at the Woodcroft Library, taking part in the baby time and toddler time sessions, Words Grow Minds, and outreach programs. Reading books and interacting with young children and their families has given me a renewed sense of purpose. There have been so many important people that have been there in my journey so far and continue to be big supporters in my life, and I want to take a moment to thank them. I want to specifically mention the support from VanaCare. The team have been an integral part of my recovery journey from the very beginning. Thanks Jason, Jesse, Holly, Ben, Timo and Reese, and the team of the other support workers for all you do. I also want to thank the BISA team, specifically Gab and Cassie and the team at the Southern Hub, for not only helping me with my recovery, but for moving me closer to achieving my goals, one of which is public speaking and sharing my story. Starting with small speaking events, the team has supported me in incrementally increasing the opportunities to now find myself here today as MC. Thanks VanaCare, and thank you BISA for everything. And thank you all for allowing me the space to be myself as your MC today. I truly am grateful to be here to share my story and to be inspired and informed by the guest speakers today. Before I introduce the CEO of Brain Injury SA to come to the stage to officially start the event, there are a few housekeeping items I need to let you know about. Firstly, in the unlikely case of an emergency where we need to evacuate, please calmly follow the convention centre staff out to the riverbank or another appropriate evacuation site. The BESA team here present are all here to assist you too. For those of you who haven't been to the convention centre before, there are ample toilets available, including accessible toilets. When you head out the room, turn to your right to locate them. The convention centre or BESA staff will also be able to point you in the right direction should you need help. We understand that at times there may be a need to step out and have a break from the event. There is a room located also to the right of this space that has been reserved for us as a breakout room for finding some quiet. And finally, there are a number of exhibitors in the foyer. Please say hi and have a chat to them during the breaks if you are able to. They are all wonderful supporters of the community. I'd now like to welcome Tanya Lancaster, CEO of Brain Injury SA, to the stage to say a few words. Thank you.
Thanks, Mel. I actually think we should give Mel another round of applause. What a milestone moment. And Mel, we are so proud that we have been able to play a part in the journey that you have been on. For those that don't know me, as Mel said, I am the CEO of Brain Injury SA, and I have had the privilege of leading the organisation since the beginning of this year. So for me, the organisation has a very, I'll try not to get emotional, has a very heartfelt purpose. So as a 19-year-old, my dad acquired a brain injury after surgery for a brain tumour. So I moved back home and helped my mum support my dad until he unfortunately passed. Sorry, I always get emotional when I talk about that. Fast forward to today, I'm now the carer of a mum who lives with Parkinson's. So today's session is incredibly important to me. And so I just want to start by saying a huge thank you to the sponsors that we have here today who make events like today possible. So if you can just take some time to appreciate these people with me, I just wanted to say a huge thank you to our presenting partner, Lifetime Support Authority. Thank you for your ongoing support each year for this important event. And for presenting, Rick, as the Chief Executive of Lifetime Support Authority, will be presenting the Embrace Life After Brain Injury Award a little bit later. To our major event partner, Livability Care Australia, thank you for coming on board with us this year. We are proud to be working with you and bringing our organisations closer together to support people with an acquired brain injury. To our gold sponsors, health partners, our partnership together is important in fostering holistic health and wellbeing support. Thank you for seeing the importance of our mission and for joining us this year for the first time. And thank you to our wonderful silver sponsor events, Be Remarkable, Nurse Next Door and Medimart, who are back for their third years. During the breaks, please take some time to go out and speak to our partners in the foyer and learn more about the support that they provide to the brain injury community. I also just want to say a special thank you and mention to Heartfelt Support for facilitating the art activity amongst our exhibitors. I've already been out and done my little bit of artwork, so I encourage you in the break to likewise go and do the same. And finally, I would like to thank those of you in our audience who have made a donation to support our event. It is truly a wonderful gift. And lastly, a massive thank you to everybody who is here today in person and for those who are also joining us online. Without your attendance, this event would not exist. I'd now like to invite somebody who has a very important role in our organisation. Catherine Ailes is what I call my chief clinician. She always laughs when I call her that. But she's our manager of allied health. And I'd like to invite her to the stage just to say a few words about this year's topic and to introduce our first speaker. Thanks, Catherine.
Thanks, Tanya. So Brain Injury Awareness Week is a nationally recognised week which serves as a dedicated time for all of us impacted by brain injury to come together and amplify our voices to increase public knowledge and understanding about acquired brain injury, which we know impacts more than 1 in 40 people in Australia. Our Brain Injury Awareness Week's event's purpose is just that, to raise our voices louder and to share the different experiences of brain injury, including personal stories, as not only is every brain injury different, but so is everyone's experience. Across the years, we have introduced and talked about a number of different topics in relation to acquired brain injury, touching on traumatic brain injury, brain cancer, stroke, motor vehicle accidents, and more. But something that has stood out to us this year, where we have identified a gap in knowledge and understanding, is in the space of progressive neurological conditions. So what does that mean? A progressive neurological condition, also referred to as a neurodegenerative disease, are chronic conditions that damage and destroy the nervous system over time, particularly impacting on the brain. Progressive neurological conditions include diagnosis of Parkinson's, Huntington's, dementia, motor neurone disease, Alzheimer's, and chronic traumatic encephalopathy, commonly referred to as CTE, as well as others. It is estimated that 50 million people worldwide are impacted by a progressive neurological condition. At Brain Injury SA, we support adults with an acquired brain injury, no matter what the cause or diagnosis, including supporting people under this umbrella of progressive neurological conditions. We encourage you to please speak to our team, and if you'd like to learn more about the work that we do or how we may support you or a loved one. To help us discuss this topic further, we have brought together some great speakers from the University of Adelaide, the Hospital Research Foundation, and Dementia Australia to share a little about the work that they are doing in this space. We are also thrilled to have with us 2 dementia advocates who will share their stories on living with dementia. So without further delay, I'd like to welcome to the stage our first speaker for the day, Associate Professor Lyndsey Collins-Praino. Lyndsey is a behavioural neuroscientist with a PhD from the University of Connecticut and postdoctoral training in cognitive neuroscience and neuropsychology from Columbia University Medical Centre. Now calling South Australia home, Lyndsey leads the Cognition, Ageing and Neurodegenerative Disease Laboratory, known as CANDLE, at the University of Adelaide, where her research takes a bench-to-bedside approach in understanding cognitive decline in ageing and neurological conditions, which includes understanding Parkinson's disease and traumatic brain injury. Lyndsey has a particular interest in the links between traumatic brain injury and neurodegenerative disease, and she's attracted over $11 million in competitive research funding for research in this space. She has published more than 85 peer-reviewed papers and was named a South Australian Tall Poppy in 2016. Lyndsey is also a passionate advocate for involving people with lived experience in research and ensuring that the work being done translates into real-world impact. Welcome, Lyndsey.
Thank you so much for that lovely introduction, and thank you for the opportunity to share our work today. So I wanted to start off, we'll just wait for the slides to come up. I wanted to start off by talking about the impact that traumatic brain injury has. Everyone in the room sitting here today knows how significant of a problem traumatic brain injury is. But what does it look like globally? And why do we need to be so concerned not just about the injury itself, but about potential long-term impacts? So there are 69 million people worldwide who sustain a traumatic brain injury every year. They can range in severity from more mild injuries or concussion, all the way up to quite severe brain injuries. About 3/4 of these are mild or concussion in nature, and traditionally it's been said in the field that most people who've experienced a concussion will recover fully within about 2 to 4 weeks post-injury. However, recent research that's been emerging has shown that not only do 5 in 10 concussions go unreported, so we don't actually know what the recovery pathway of those individuals is, but that 20 to 50% of people who've experienced a concussion actually report ongoing change following initial injury. So let's look at that a little bit closer. Now, when we look at the majority of concussion symptoms, it's true that they do recover by about 1 month post-injury. So here we can see that over a 4-week period, there's a reduced number of symptoms and also a greater likelihood of becoming asymptomatic. The light gray line here corresponds to females and the dark black line to males. So you can see that there are sex-related differences in this recovery process. However, while the majority of individuals do recover within that 4-week window, it's not the case for everyone. So this study came out of the US and is showing that when we look at time post-injury in months over that sort of first year and a bit post-injury, well, there is a reduction in the percentage of participants who report injury-related problems. 53% still do report changes even at 1 year post-injury. This was significantly greater than an orthopedic control represented here in orange who had not experienced a head injury. And similar long-term persistent impairment has also been reported across other studies. So this study looked at 2 years post-injury in a UK cohort and found that even at that 2-year period post-injury, the furthest point on the x-axis in each of these graphs, individuals had persistent neurological symptoms as measured by scores on the Glasgow Outcome Scale, as well as more post-concussion symptoms, reduced quality of life, greater psychological distress and depression, and even greater harmful drinking compared to individuals who had not experienced such an injury. So currently, predicting an individual's prognosis following traumatic brain injury looks a lot like this. When someone actually experiences a traumatic brain injury and goes to the clinic, it's really difficult to tell who's going to recover fully, who's going to experience persistent impairment, and even what those persistent impairments may look like. And part of what drives this is the fact that many individuals aren't adequately assessed and cared for beyond that immediate period post-injury. So it's clear that we need better ways to predict long-term outcomes following traumatic brain injury. And spoiler alert, this is where a lot of my research comes in. Because when we know who's at risk for persistent impairment, we can have better discharge plans and specialist referrals, better education for both the patients, caregivers, and clinicians about expected outcomes post-injury, engagement with potentially beneficial strategies such as rehabilitation, enhanced monitoring and follow-up of individuals who've experienced brain injury, and even earlier identification of good candidates to enroll into potential therapeutic trials. So there's benefits across the board. But despite this, we know very little about long-term outcomes following traumatic brain injury. My group has looked recently at motor outcomes following traumatic brain injury because it's been said that motor impairment is one of the earliest indicators of chronic impairment post-injury. So this is Dr. Ying-Chi Wee here, and she started with 24,000 studies when she initially did her systematic review criteria. And after scanning that against our inclusion criteria, we found that only 97 studies ever conducted in the literature looked at long-term motor outcomes post-injury. And we define that as more than 1 year post-injury in the clinic and greater than 1 month post-injury in preclinical models. So there were about 62 clinical papers and only, about 62 preclinical papers and only about 32 papers that we found in the preclinical models and clinical models. So we found really mixed results when we looked at motor performance. In general, more persistent motor deficits were associated with more severe injuries, so there appeared to be a dose-dependent effect. And we even found after repeated concussions, such as an athlete on the field might experience over the course of their career, that there were detectable and persistent fine motor deficits and balance and coordination deficits even years post-injury. However, it was really difficult to draw set conclusions. And one of the things that made that so challenging was that there was a real mix in the types of participants who had been included in studies, and also there was a lot of difference in terms of the types of tools that were used to assess motor function, and many of these were quite blunt rather than looking at specific motor domains. So it's really tricky to know actually what someone's long-term motor function might look like, and it's quite a similar problem when we look at other common outcomes after traumatic brain injury, such as cognitive change or mood change. So we've been looking at this preclinically in our models, and we've looked up to 3 months post-injury at this stage, but are following out longer. And we found that when we look at multiple different domains, both of traumatic brain injury alone and when administered in combination with another major risk factor for Parkinson's, which is pesticide exposure, we find injury-specific effects on balance, motor coordination, and limb movement following moderate to severe injury. And as I said, we're currently assessing longer time points to see how those bear out over time and how they're related to initial severity of injury. So here you can see that when we look at latency to cross or the number of foot faults, which are both measures of motor coordination and balance, or when we look at the number of adjusting steps, which is a measure of limb position and limb movement, there's detectable impairments even at these quite long-term time points, preclinically speaking. So what's clear is that we don't know enough about long-term outcomes after traumatic brain injury. And one of the reasons that this is particularly concerning is because traumatic brain injury is associated with increased risk of various neurodegenerative diseases. The one that we hear the most about in the media is CTE, or chronic traumatic encephalopathy, but there's also a literature around the link between other forms of dementia, including Alzheimer's disease following traumatic brain injury, motor neuron disease, with studies out of Scotland suggesting that rugby athletes have 15 times the risk of the general population of developing motor neuron disease, and one that's of particular interest to my group, which is Parkinson's disease. And we'll look at that in a little bit more detail in just a moment. What we do know is that across the board, traumatic brain injury increases the risk of neurodegenerative disease in a severity-dependent manner. So the more severe the injury, the greater the risk of developing a neurodegenerative disease. And you can see that represented here by the red line, which is a moderate severe injury, versus the blue line, which is mild traumatic brain injury. It's looking at hazard ratio over time. And you can see that particularly as individuals get older, those who've had a more moderate to severe injury have an elevated risk. And while we're not clear on exactly why this may be, what studies have suggested is that traumatic brain injury may actually accelerate the normal aging of the brain, and that may lead to earlier onset of neurodegenerative diseases. So for example, here you can see the course of normal aging where an individual doesn't cross clinical threshold for neurodegenerative disease. And you can see for various neurodegenerative diseases, including Alzheimer's disease, Lewy body dementia, frontotemporal dementia, and the conversion from mild cognitive impairment to Alzheimer's disease, that all of these are accelerated in individuals with a history of traumatic brain injury. But it's very important to note that this is not a certain outcome. It's not a one-to-one. So it's absolutely not that everyone who's ever had a concussion or a traumatic brain injury will develop a neurodegenerative disease. We know that these are still quite rare outcomes. We just know that relative to people who don't have such a history, we see this elevated risk. So let's look at Parkinson's disease in particular and talk about why my group is interested in Parkinson's disease in particular and the link between traumatic brain injury and Parkinson's. So there are currently 8 to 10 million people worldwide living with Parkinson's disease, 110,000 cases here in Australia. And while we hear a lot about dementia and Alzheimer's, sometimes we hear less about Parkinson's disease and don't realize that it's actually the fastest growing neurological disorder. There's 90,000 new cases every year in the United States alone, and the prevalence of Parkinson's disease doubled between 1990 and 2015, and is expected to double yet again by 2040, which is really just around the corner. So it's very quickly growing and affecting a very large number of people. On average, there's about 37 new cases diagnosed every day here in Australia. So when we take a closer look at traumatic brain injury and Parkinson's disease, about a third of people with Parkinson's disease have a history of traumatic brain injury with loss of consciousness. And when we look at people who have that history of traumatic brain injury with loss of consciousness, we know that it increases the number of cases of Parkinson's disease quite significantly. And this was done in a prospective study across multiple longitudinal studies of aging. So they're able to really look at how this risk developed over time, from when someone had a traumatic brain injury to when they actually developed Parkinson's disease. So that study was not retrospective in nature, which is important because sometimes with retrospective studies, it could be that someone had Parkinson's and then that caused them to have the fall, which resulted in the traumatic brain injury. This is prospective, so it takes that issue out. There's been a landmark study by Gardner and colleagues in US veterans, which suggested that a mild traumatic brain injury or concussion increased risk of Parkinson's disease by 56%. And a more moderate or severe injury, such as someone might sustain in a car accident, increased risk by 83%. And you can see that in the graph here, where people who do not have a traumatic brain injury are with the black line, mild concussion is with the blue line, and more moderate severe injury with the orange line. And you can see that over that follow-up time, over a 12-year period, the incidence of Parkinson's disease increased quite significantly, again, in a severity-dependent manner. So one of the questions my group was interested in was, we know that having a history of traumatic brain injury increases the risk of Parkinson's, but once someone has Parkinson's disease, does having such a history change the progression of Parkinson's? Because Parkinson's can be quite heterogeneous. It can really look quite different depending on different people. So Dr. Angus McNamara, who's in the back, did this work as part of his PhD thesis, and we utilized what's called the Parkinson's Progression Markers Initiative, or the PPMI database, which collects data from all over the world and follows people every year from time of Parkinson's disease diagnosis forward. What we found was that, consistent with the other literature, people who had Parkinson's with a history of traumatic brain injury had an earlier age of onset compared to people who didn't, so they were younger at the time that they received their diagnosis, but they weren't any different in terms of their education or sex. So it didn't seem like there was any specific vulnerabilities for having a history of traumatic brain injury. Now, Angus looked across just about every marker you can think of in this data set. There are a lot of graphs here. Let me point out the important points. So we looked at various biomarkers, from dopamine binding in the striatum, which dopamine is a chemical that helps you to move normally. And in Parkinson's disease, there's a loss of dopamine. So we looked at whether or not that loss of dopamine was worse in people who had a history of traumatic brain injury versus who didn't. We looked at various proteins in the cerebrospinal fluid that we know are associated with Parkinson's disease and dementia, like tau, amyloid beta, and alpha-synuclein. We looked at cognitive and mood ability, because what's sometimes underappreciated about Parkinson's is that they have quite a non-motor component as well, which can be much more predictive of an individual's quality of life. And then we looked at the classic motor symptoms of Parkinson's. The thing to really take away is that people with Parkinson's with a history of traumatic brain injury are the blue line, people without a history of traumatic brain injury are the orange line, and what you see is those lines don't really differ over a 5-year follow-up period. So what we found was that having a history of traumatic brain injury didn't appear to change progression overall in people with Parkinson's disease. However, when we looked at various variables related to the traumatic brain injury, we did find some associations. So particularly when we looked at TBI severity, more severe injury was associated with worse dopamine dysfunction, so they had less striatal dopamine binding, and increased mood dysfunction. So it seemed to, perhaps for non-motor outcomes and for dopamine, that the severity of injury seemed to impact how someone progressed. So this is something that we're looking at more in our own work now. And it really illustrates an important point, which is that traumatic brain injury is not a single event. It's an ongoing process. Once someone has what we call the primary injury, which is actually the acceleration and deacceleration and the rotational forces that the brain experiences when it's injured, it starts a whole host of other processes in the brain. This can include things like mitochondrial dysfunction, oxidative stress, excitotoxicity, and one that my group's really interested in, which is neuroinflammation. We know that a bit of neuroinflammation is good because it helps you to respond to injury, it helps you to respond to infection. But what happens in traumatic brain injury is that that becomes an abnormal inflammatory response, and we'll talk about that in just a moment. what we're really interested in is knowing that there's all these secondary injury factors that happen in the days, the months, the years post-injury. Can we track these biomarkers and the associated changes in the brain to predict who has experienced a traumatic brain injury, who will have persistent impairment, or even who will be at eventual risk of developing Parkinson's disease? And this is particularly relevant in Parkinson's disease because we know that by the time someone's clinically diagnosed, which is this dotted line here at time 0, anyone want to take a guess what percentage of the dopamine in their neurons in their brain they've already lost? How many say 10% before motor changes? Show of hands. 20? 30? We'll skip ahead a little. 50? Getting more hands. 60? It's over 60% of their dopamine neurons, and this means that they've had about an 80% loss of dopamine within that part of the brain we talked about before, the striatum. This is a catastrophic loss, and it means that therapies can have limited utility because once neurons are lost, once brain cells are lost, at this stage, we're not able to put them back. So what we know is that prior to that time, people show a constellation of symptoms known as prodromal symptoms. These can occur in the years or decades prior to Parkinson's disease diagnosis and can include things like REM sleep behavior disorder, where people thrash out in the part of sleep where they dream. They can often act out their dreams or can become quite disruptive, shouting out, sitting up. You can also have depression and anxiety, olfactory loss, changes in GI function like constipation or urinary dysfunction. In males, you can see erectile dysfunction, and orthostatic hypotension, which is a drop in blood pressure, particularly upon standing up. And we know that these are occurring for years or decades prior to that time of clinical diagnosis. So we were really interested in, could we track those sorts of prodromal outcomes in survivors of TBI to help potentially identify risk of conversion or risk of persistent impairment? And so what drives that elevated risk of Parkinson's disease following traumatic brain injury? What biomarkers should we be looking at? Well, I'll just walk you through a very quick pathology of Parkinson's disease. Sitting right in the middle of your brain, there's this little structure here. It's in the middle of your brain, and it's conveniently called the midbrain. And what happens in Parkinson's disease is, notice that in an individual without Parkinson's disease, there's these two black bands. This is called the substantia nigra. It sits in the middle of your brain, and substantia nigra literally means black substance. And the reason that it's called substantia nigra is because these dopamine neurons contain a pigment called neuromelanin. And just like melanin gives your skin its color, neuromelanin gives color to these dopamine neurons. What ends up happening in Parkinson's disease, for reasons that we don't quite understand, is that those dopamine neurons die away, so you lose the pigment, so you get this really washed out appearance of that substantia nigra right in the middle of your brain. Why is that a problem? Well, because dopamine, which is what those neurons release as their chemical, helps with normal motor function, it helps with decision making, it plays a role in mood. Dopamine is really the all-arounder of the neurotransmitter world. And what ends up happening when you lose those dopamine neurons is they send that dopamine to many different places in the brain. One of the places they send it to is that striatum we mentioned before in orange here, and that's really important for that normal motor function, and that's when you start to see those characteristic motor symptoms of Parkinson's. We don't know why those dopamine neurons die. There's a lot of reasons those neurons are really vulnerable, but they should be sort of universally vulnerable in everyone, and they're not. So, another major player in Parkinson's disease is a protein called alpha-synuclein. So alpha-synuclein normally sits in your synapses, and it helps your brain cells to send messages between one another. But what ends up happening in Parkinson's, again for reasons that we don't quite understand, is that that protein goes from being a helper protein to send those messages to getting really sticky and really clumpy. It's attracted to itself, so it really wants to form these little aggregates and clumps. And that's what we see happen, where it forms these really big clumps, and we call those Lewy bodies. And they sit in the neurons, and they make it really hard for those brain cells to have normal function. And those Lewy bodies are particularly problematic because they don't just stay in substantia nigra. In fact, they don't even start in substantia nigra. They start way down in the brainstem, even in the gut. There's been a lot of research in recent years about the gut and Parkinson's disease, as well as in the olfactory bulb, smell. And that's why we think that loss of sense of smell is such an early marker. And they then move up, they eventually hit the midbrain, and that's when you start to see the classic motor symptoms. And then they spread throughout the rest of the brain. And that's when you see things like the cognitive change and the mood change that we see in Parkinson's. So after experimental traumatic brain injury, that protein, alpha-synuclein, that gets clumped up, it starts to be elevated. This is in preclinical models. So they did this in a blast injury model, such as like a veteran might experience from being exposed to blast injury on the field, and showed a significant upregulation over time in alpha-synuclein. And it's been shown to persist even out to 8 weeks post-injury. So it seems to be quite a long-lasting response. And this has been shown to occur in clinical TBI as well. So CSF levels, so levels in cerebrospinal fluid, have been shown to be 5 to 10 times higher in people who have traumatic brain injury. And this has been seen in both adult and pediatric populations. And post-mortem studies have also found alpha-synuclein accumulation in axons following traumatic brain injury. So we have preclinical evidence of alpha-synuclein becoming abnormal, and we have clinical evidence. And actually, alpha-synuclein levels were the best predictor of chance of death following a traumatic brain injury. And it's also one of the earliest changes that we see in the brain of people who have Parkinson's. Now, not so fast, because nothing's ever simple in science. Dr. Alina Aralsami from my lab looked to see whether or not these persisted long term, and she found that when we looked out to a year post-injury in our preclinical model, there were no changes in any of those parts of the brain we've talked about, like substantia nigra or striatum. And this is consistent with other preclinical studies that have shown that around 16 weeks post-injury, you see a return to normal. And they've looked in older veterans with a history of TBI, and found that exosomal alpha-synuclein levels also weren't elevated. So is this something that just occurs transiently after injury or not? We're not really sure at this point. It really needs more following up. And one of the things that's really limited the ability to do that is until last year, there was no really good way to measure alpha-synuclein outside of their cerebrospinal fluid. In humans, that totally changed last year. And we can talk more about that during question time. Okay, so we're not really sure if it's alpha-synuclein. Could it be neuroinflammation? Now, as we talked about, we know that inflammation happens really rapidly following traumatic brain injury. And in Parkinson's disease, neuroinflammation seems to drive the degeneration of dopamine neurons. And the cells of the brain that are important in that neuroinflammatory response, which are called microglia, they stop having their good function, and they start to have really detrimental functions. So we've got neuroinflammation right after injury. We've got neuroinflammation right after Parkinson's disease, driving Parkinson's disease. What happens in between? I'm glad you asked. So there's a lot of evidence that there's a chronic neuroinflammatory response long term, that it doesn't just occur after injury and then go back to baseline. In fact, autopsy studies looking at people who had a history of traumatic brain injury and then passed years later have shown that you can still detect elevated microglia in their brains. And you can say, well, but, this is autopsy, lots of things change at death. How do you know it's not just, something to do with that? Well, because there's also tracers that you can use to look inside the brain. And those studies using PET scan have shown that you get activation of those cells that are important in neuroinflammation even 17 years post-injury. So it's a really long-lasting effect. We've looked at this in our preclinical model and found that when we look at brain areas that are relevant to Parkinson's, like the striatum, and the prefrontal cortex, we can detect elevations in the total number of neuroinflammatory cells and also elevations in how active they are, so how much detrimental function they have, even up to a year post-injury in our preclinical model. So really long-lasting effect. And this neuroinflammation was associated with behavioral changes even at 12 months post-injury. So we found that our preclinical model was able to learn a task equally well when you tested their cognitive ability to switch from doing one thing to doing something else, which we know is something that can change after traumatic brain injury. Even at a year post-injury, moderate severe injury was associated with changes in that ability to switch that cognitive rule. So how does this reflect what's seen long-term in survivors of TBI? Well, this is the FIND TBI study. Some of you may have had a preview of this when you went out and talked to our group, hopefully. But basically, FIND TBI stands for Forecasting Risk of Long-Term Impairment and Neurodegenerative Disease Risk Following TBI. Ugh, that's a mouthful. You can understand why we say FIND TBI. What's FIND TBI all about? Well, FIND TBI is really hypothesis-driven. Basically, what we say is that people who've had a traumatic brain injury develop that chronic neuroinflammation, and that drives the death of brainstem neurons, which are really highly vulnerable, leading to persistent cognitive and motor changes and potentially the emergence of neurodegenerative disease. And so we've been recruiting 800 people here in South Australia. It has been quite the labor of love. That includes 100 healthy controls, 100 people with Parkinson's disease, which serves as our positive control, and then we've been recruiting 600 people who've had different severities of traumatic brain injury and are at different time points post-traumatic brain injury. And for each of these steps, we have a really hypothesis-driven way of looking at it. So for traumatic brain injury, we have questionnaires where we get lots of detail on the injury, excuse me, and we also do medical confirmation wherever possible. We've been doing blood-based biomarkers and saliva-based biomarkers to really characterize the neuroinflammatory response. We've been using structural MRI and functional MRI to look deep inside the brain at areas that are not traditionally accessible. And we've also been directly measuring dopamine levels using PET scans. We've custom designed our cognitive and motor batteries to be really relevant to the types of changes we see in Parkinson's disease, so that we can look at those brain circuits that are involved and how healthy they are in survivors of traumatic brain injury. And then we've looked at blood-based biomarkers of neurodegeneration, and we're doing all of our comparisons to a Parkinson's group. So this study's still ongoing. Thank you. This study's still ongoing, so we don't want to share too much data yet because we're just really delving into it. But remember those prodromal symptoms that we talked about, that constellation of symptoms? Well, the Movement Disorder Society has come up with a calculator that you can use to weight these differently and see what your prodromal score might be. And so we took a subset of our FIND TBI cohort, healthy controls, people with traumatic brain injury and Parkinson's disease, and we looked at their expression of all of these prodromal symptoms, and we weighted them based on those Movement Disorder Society criteria. So the maximal possible score that someone could have was a 24.6. And what we did then is we looked at the expression in people with TBI, and this was done by our honors students Silas and Angus, and we found that on a variety of different prodromal symptoms, from the non-motor symptom questionnaire to measures of anxiety and REM sleep behavior disorder, cognitive function, olfactory function, people with a history of traumatic brain injury were impaired compared to age-matched controls on all of them. And when we looked at the overall prodromal score, there was a significant elevation in people with a history of traumatic brain injury compared to those without. And when we looked at the factors of injury that seemed to predict that prodromal score, what we found was that the number of traumatic brain injuries that someone had had resulted in a higher prodromal score. Interestingly, not severity. So it wasn't that the more severely injured people had a higher prodromal score. It really seemed to be tied to the number of injuries that they had had. And that sort of matches up a lot with the literature we're seeing come out of the athletic space, people talking about the dangers of repetitive concussions in particular. Now, when we looked at substantia nigra volume overall in the group, we didn't see any group-level differences. But it's important to keep in mind that not everyone who experiences a traumatic brain injury goes on to develop Parkinson's. Remember, it's quite a rare outcome. So what we did is, well, what they did was go into the substantia nigra and trace these 3D masks on T1-weighted MRIs that actually picked out the substantia nigra. And when we just looked at people who had TBI who had the highest prodromal score, what we found was that they had significantly reduced volumes compared to people with the lowest prodromal score. So this is very preliminary, but we didn't see that same effect in healthy controls. So we've only done it in a subset. We need to look in the wider data set. But what this suggests is that we may be able to use neuroimaging and prodromal symptom expression to potentially predict who should be monitored for those early signs of Parkinson's, long before a concern of Parkinson's is even on the table. It's also important to keep in mind that substantia nigra, as we've talked about, is really late degenerating. So that's quite late in the spread that we talked about. So maybe if we look at those earlier regions where we see that alpha-synuclein, like the olfactory bulb or the lower brainstem, we might be even better able to predict this risk. So in support of that, we've looked at olfactory function, and the Parkinson's group, of course, was reduced as you would expect. It's a common symptom of Parkinson's, but our TBIs were significantly reduced compared to controls. So we're now using MRI to look at this more. So this is just our PDs versus our controls, but in multiple brain areas that we know are associated with smell, with olfactory function, we see significant decreases in Parkinson's. So we're really interested in, could the same be true in traumatic brain injury, and could this be another early marker? And in line with that, our group's will be the first to detect the nigra olfactory tract in humans. So this is a tract that was only reported in 2015 using axon tracing in preclinical models. And basically, this is a tract that connects your olfactory bulb to that substantia nigra in the midbrain where your dopamine neurons are. So we think that this could be the tract that causes environmental toxins to be able to reach those deep areas of the brain. And so by tracing this tract, we can look at whether this is an earlier predictor of risk in TBI survivors as well. So what do we do with all of this? Well, we harness the power of machine learning because we have tons of data. So we take all of those different types of measurements that I was talking about, and we use machine learning in order to try to generate algorithms that could potentially predict risk of what someone's recovery journey might look like after traumatic brain injury, and even eventually what their risk of Parkinson's may look like. Because at the end of the day, the future of medicine is personal. Currently, long-term prognosis after concussion for the individual is unknown. We know that a subset will continue to have impairment long-term. So by understanding brain mechanisms that underlie this risk, we can achieve earlier identification and more effective interventions, and hopefully provide clinicians the tools that they need to inform individuals about their prognosis. So I'd like to thank the Candle team, all of the Find TBI team and collaborators. There's lots of them, and these are three of my main collaborators who help drive all of the different analyses you've seen today. Hospital Research Foundation Parkinson's is instrumental in helping us to reach the Parkinson's community, and we have a variety of funding partners who've enabled this research. So thank you so much for giving me the chance to share our research. If you've experienced a TBI or concussion, or you know someone with Parkinson's disease, please email us, use the QR code, visit our table, visit our website, send us a carrier pigeon, send us a smoke signal, get in touch somehow. The study will be continuing to recruit throughout this year and the early part of next year. Thank you so much. I'm happy to take any questions.
So are you saying that a child who has a brain injury that's perhaps not diagnosed at the time, or concussion, that the effects of that can affect a larger part of their life growing older?
So what we found when we looked at prodromal score was actually that pediatric TBI was protective against that prodromal score elevation. So it seemed like for children who had experienced a brain injury or concussion, they actually had significantly lower prodromal scores when we looked at that prediction. So it's complex. So we have not seen it with that prodromal score in the subset we've looked at so far. However, the wider literature has suggested that even pediatric concussion can have detrimental outcomes. We know that adolescence is one of the most common times for people to experience traumatic brain injury. They can have quite challenging recoveries after that for a subset of individuals. That has a lot to do with the fact that many of these brain pathways that I talked about, the dopaminergic pathways, they're really only maturing as people come into their early 20s, mid-20s. So adolescence is a really vulnerable time for those brain pathways. So it's been understudied. We have a grant in now to under consideration to hopefully be able to look at that, but they haven't informed outcomes yet, so cross your fingers.
So would that explain, like, teenagers and young adults perhaps not behaving what they call inverted commas normal and have issues and mental issues, or etc.?
So the fact that many brain areas, particularly areas like the prefrontal cortex, which is really important for attention and decision making and inhibiting responses, risk-taking, those areas are really under development in teenagers and adolescents. So we know that it's not really, I mean, people used to say early 20s. Now we know it's probably more mid to late 20s that those areas are really fully functional. Anything that's in development where you're counting on connections in the brain to begin to function normally, any hit to the system at that time when it's vulnerable and developing could have potential deleterious effects. So that could help to explain some of that. We know that adolescents compared to adults can show very different recovery patterns after traumatic brain injury. And even seemingly minor concussions can have quite marked effects in a subset of adolescents. There's been a couple of studies in the adult population looking at what are predictors of persistent impairment. Female sex is one, pre-existing history of mental health disorders is another. We think that it's probably similar to adolescence, but it is a massive hole in the literature. The assessments that you use in adolescence aren't as well developed. The understanding of persistent impairments not as well developed. So our grant's called for a study called PEDS TBI, and so it will answer those very questions if successful.
Could I just ask if there's a link between TBI and stroke, please?
It's a great question. The thing with traumatic brain injury is it's more linked. So what you see after traumatic brain injury is that you get this shearing of the axons, which is how your brain cells talk to each other. And that's what we think leads to that accelerated aging of the brain, changes in connectivity, some of the neurodegenerative profile. You don't see that so much when you look at the relationship between TBI and stroke, because they're quite different events in terms of their pathophysiology. Now, that being said, stroke is also a major predictor of neurodegenerative outcomes, particularly dementia. So stroke can have secondary neurodegeneration that occurs after it. And so you can get sort of multiple things meeting, because we know that people are complex, right? Someone who's had a concussion may also have a stroke, or someone who's had a concussion may also be exposed to high levels of pesticide or have a combination of risk factors that we know are associated with these neurodegenerative outcomes. So not on its own, but in conjunction, it can really make these things quite complex.
If you've had a traumatic brain injury and you think you might be heading towards Parkinson's, what can you do?
So at this stage, if you have concerns about whether it be dementia or Parkinson's or any neurodegenerative outcome, if you're worried that you're showing symptoms of those disorders, I would say to definitely go to your GP and have them do the first assessment. So early detection is really critical, and they can make referrals if they deem them appropriate. If you're not sure what those early warning signs might be, or if you need more support, there's also really great support organizations, which we'll hear from later today, like Hospital Research Foundation Parkinson's and Dementia Australia, who are really well versed in when should someone be worried, what are those early warning signs, what's possible for them to do.
Hi. I was just wondering if there's any recommendations you can make how people could improve
their risk or the outcomes? So, for example, like exercise, or what kind of practical, functional things can people do to improve their outcomes?
Yeah, that's a fantastic question. So there's been some literature coming out, like Gil Livingston studies, which have suggested that if we targeted what we call the 13 modifiable risk factors, do you know how many cases of dementia we could prevent? 40%. These include things like exercise, prioritizing your heart health by keeping cholesterol low and prioritizing cardiovascular health, but also things that you may not expect. So we all know you need to eat well and you need to exercise, but did you know that untreated hearing loss can also be a risk factor for dementia? So if you notice hearing changes, getting those addressed. Mental health is really important to prioritize as well. As I mentioned, we know that the history of mental health disorders can be a predictor of more persistent impairment following traumatic brain injury. We know that they can be linked to neurodegenerative disease. So it's really critical that you seek treatment for mental health concerns the same way you would physical health concerns. Staying really active and engaged. So being here today and learning something and meeting people and talking is a really great way to stay engaged, particularly in older adults. We know that loneliness is really an epidemic. People aren't getting out, they're not meeting each other, they're not connecting with each other. The advent of food delivery apps, for example, are wonderful in some ways, but it also means you no longer have to walk to the grocery store to go and speak to people there and find things. So keeping your body active, keeping your brain active, and keeping your social life active are some really sort of practical things you can do to reduce that risk.
We did have a question on the Slido. So somebody's asked about the effect of epilepsy and TIA on the brain.
Mm-hmm. So we know that epilepsy or seizures after TBI can be, it's a relatively rare outcome, but it is something that you do see in a subset of people. When you look at epilepsy, essentially what a seizure is that the firing of your brain becomes too in sync in different areas, and that leads to a seizure. It depends where the seizure is. It depends how long the seizure goes for, how extensive it is, how often it repeats. All of these will impact someone's recovery. When we look at TIA, which is a transient ischemic attack, which previously was called a mini stroke, the field has moved away from that terminology right now. That's more where you have a temporary blockage of blood flow to the brain, which then is resolved. Usually symptoms will disappear within minutes, but it can set the stage for future reoccurrence of stroke. We know that particularly in those first few days after transient ischemic attack, you're at the highest risk of stroke that someone will be. I believe it's about 20% of people within a 5-year period after TIA go on to have a stroke, but it depends on where it is again, and there's a variety of other factors that can contribute to that. So they're both relatively nonspecific. It depends on the individual level what someone's outcomes will be. Any other questions? Yes.
Yeah, I just wanted to ask about when you were talking about sport before. Mm-hmm. I've heard in the news about children and playing soccer and headers in soccer. Mm-hmm. So is that sort of injury sufficient to cause a problem?
Oh, you're going to get me in trouble. A couple of years ago, the US and the UK and various other countries banned heading of the soccer ball in children. The rationale for that was that sort of repetitive contact, particularly in children who may not know how to do so safely, can really add up to significant issues down the track. We know that it doesn't even have to be a formal concussion. There's a literature coming out that subconcussive impacts, which are just the impacts to the brain that don't result in a concussion but that sum up over time, may be even more detrimental because they're not recognized. And so people may not change their behavior. They may not sort of slow down if they don't know that something's gone wrong. Australia has not decided to follow with that international approach, and the rationale that was presented at the time was that they felt that because heading the soccer ball is really common in the professional level sport and as you get higher up in soccer, that it was really critical that children learn to do so safely at that level of play. I'm not allowed to share with you my personal opinion about that is, but that was the decision that was made nationally here. That hasn't changed. However, there's been a lot of conversations around safe return to sport. There's been a lot of conversations around how do we make sure that someone who's had a concussion following sport is adequately cared for before they return to play. And so I think that it's really great that those conversations are happening. And I think that it will hopefully spur a wider dialogue.
So I think that's all the time we've got questions for today for Lyndsey. But if you have asked a question, Slido, we will get back to you to answer those. Thank you.
We'll be back after a short break now at around 12:05. If you're stuck with time, listen out for me and I'll be welcoming you back in here shortly. Thank you. Hi everyone, I hope you enjoyed your morning tea. Thank you, Lyndsey, for that presentation. It was incredible. I believe you'll be available in the foyer to the University of Adelaide stand to chat and answer any further questions anyone might have. Thank you. To start us off, I'd like to welcome Robert from Heartfelt Support to the stage, who will tell us a little bit about the art installation that you've all been contributing to and a few words on art as therapy. Thanks, Robert.
Good morning. I've used a big microphone, I've got a big mouth. Now, I know you've been dragged away from really good sausage rolls and banana cake. I assure you it's not to hear me speak for 3 minutes about how wonderful our business is. So just read the brochure. It's in your books. There's a picture of a horse with his tongue sticking out. I was going to bring the horse today, but the convention centre said no. We have a big canvas out there. I don't know if you've noticed it, but it is an opportunity for you to go and draw, paint, sticker, write, shade, whatever, and contribute to a large artwork that is going to hang on a wall in Bisa afterwards as a permanent reminder of this event. And this is the third time I've been to this event and the third time I've done that sort of art thing, so we're pretty good at both of them now. Now, the reason that we wanted to do this today is it's a great permanent record of the way people feel. Now, you can write how you feel on it, but please don't put anything overtly political or that might trigger anyone else. Last time we had someone make a suggestion as to what the Prime Minister could do, and it was very creative, but not the best. So I love art, so it's very easy for me to talk about art. The particular art that I love is music. So every morning at 4 a.m, I spend 2 hours songwriting, playing guitar, recording, doing that sort of stuff, because I can't get through my day without art. And Heartfelt Support, we set up a couple of art things because we wanted to, not because it was core business, not because it was even good business. Certainly NDIS doesn't think so. But it was because we wanted to do it, because we have this belief. So a while ago, there was a thing on Twitter, a guy on Twitter, let's call him Dan. His name was Dan, some idiot called Dan. He put this thing about disabled parking spaces. And he said, why are disabled parking spaces 24 hours? People with a disability don't need to be out after dark. To which someone replied, Dan, we're disabled, we're not werewolves, which I thought was quite good. But there is this idea that if you have some sort of disability, then all you've got in your life is that disability, and you've got to spend 24 hours a day sorting that out. You know, and here's some advice that you can take or not take, and if you don't take it, I'll come back next year and tell you again. You're entitled to have fun. Everybody in this room, whether you've got a disability, whether you're one of the organisers, whether you're the lady up there collecting the cups, you're entitled to have fun. And art is such a good way to have fun. Now, I've spent 3 years arguing all the university studies that show what art can do for you. And we all know stories about someone in a nursing home that has dementia that can barely remember their own children, but you play a tune and they know every word. Now, we know that art is essential for the way your brain functions. And it doesn't matter what your art is. If your idea of enjoying art is dancing in your pyjamas to Kylie Minogue or Led Zeppelin or the Wiggles, then that's your art. And if your art is going out and doing something in public and painting or going to art therapy or going to an art class, that's all the better, but it's just as valid if you're doing it yourself. So what I really want that message, it's important. I know our good friends, the NDIS, they're really obsessed with things like physiotherapists. No disrespect to physiotherapists, but my music therapist had to go to university 2 years longer than you, and on top of that, they had to pass an audition in singing and playing an instrument just to get their degree. But the NDIS is obsessed with these things like OT and physio and speech therapy, which are very necessary, but nobody wants to go to them. But the minute you get something that's actually exciting and interesting, like music therapy or art therapy, all of a sudden we're putting the brakes on it. You know, and the best therapy is the one you actually go to, the one you look forward to. We also do equine therapy. That upsets them as well, quite frankly. I'm not talking about that today. But my message today is come and take part in our art, but please find your art. If you don't have room in your life at the moment for art, just adding it yourself, just drawing some doodles or learning to play the bagpipes, whatever. Please try to find room for art in your life, and I think you are entitled to that, and you're entitled to have some fun. Thank you very much, and I will obviously also be in the foyer like the good people at Adelaide Uni, and I'm also up for a chat, but just because I like to chat. So anyway, I will see you all around the place. Please, at lunchtime, drag yourself away from the excellent lunch and come and contribute to our artwork. Thank you.
Thanks, Robert. How powerful is art in bringing us all together? I've contributed my little piece to the canvas this morning. I can't wait to see the end result. I'd like to welcome to the stage Santosh Adhikari, Principal Business Development Director, and Maho Hart, Business Development Manager from Livability Care Australia, to say a few words. Thank you.
Hello and good afternoon. My name is Santosh Adhikari and I've got Maho De Silva and we're representing Livability Care Australia. Before we begin, can I request everyone to give big round of applause to BISA, Team BISA, and all the guest speakers. And we are honored to be proud major sponsor of this program organized by BISA. This event is very special because it gives voice to our real stories of courage, resilience, and make us all understand the journey of living with TBI. At Livability Care Australia, we provide person-centered support and tailor-made accommodation to more than 70 individuals across South Australia and Queensland. Many of them living with TBI, AVI, Parkinsons, and Huntington. Our mission is simple, but equally powerful. We support each person to live their best life filled with dignity, choice, and opportunity. So thank you to BISA for organizing this amazing program. We are honored to be part of this event.
I think Santosh kind of covered who we are, but I'll repeat. For those who don't know us, we are Livability Care Australia. We are a registered NDIS provider, and we specialize in providing supported independent living options, partnering with specialist disability accommodation providers throughout South Australia, Queensland, as well as Victoria. So we work closely with participants, their families, and communities to create a person-centered support that empowers people to reach their goals. Rather than just telling you guys all this, we do have a small video that captures who we are and what our participants say about us. Thank you again, Bisa, for the wonderful opportunity. Where's the video?
Hi, I'm Crystal. I work at Encounter Bay. I'm a support worker. I love my job. We look after 3 clients at this home. I love working at Livability. I feel safe. I feel respected. I don't feel like a number. It feels like a second home. It really does.
I had a car accident 35 years ago. It was really hard at first, but the staff have been very welcoming to me, and this is the best place for me.
Our biggest fear was as we got older and there would come a time when we couldn't care for her anymore at home. We didn't know how she was going to be looked after, and to have found this place and the care and attention, it's just like her being at home. It's hands-on, even with the owners. They come down occasionally and
they bring me a cappuccino.
Bring a cappuccino in for Tiffany. She gets a hug from them. They've taken her out for meals. It's far beyond what we thought was out there. Yeah, we're happy. I found LCA to be a fantastic company. They employ wonderful carers. They're very approachable. It's like a big extended family. When we were still living in Mildura, Brittany was in care with the company there. I found I was never confident with them. It was the hardest thing I've ever done in my life, was to hand her over. I found I couldn't sleep, and once we moved over here and brought Brittany over, the care that she receives from LCA puts me at such ease now that I sleep well. Brittany sleeps well, and we feel very confident and safe in their hands.
We support this gentleman, Jonathan. We help him with the personal care. Then he loves coming out in the community. So we normally come down to Zeddy's, walk around. He doesn't really like to swim, but we can walk around in the sand, play with the sand, throw things. Sometimes we bring the ball and play ball. Do you want to say something to it?
Oh.
No, you don't want to say nothing. Say, hi, I'm Jonathan. I live in Waila. I live in Waila, yeah.
Home is more than just a place to live. It's where life happens, dreams grow, and independence thrives. Livability Care Australia, because care begins at home.
Thank you, everyone.
It is now my pleasure to introduce our next speaker, Angela Sayers from the Hospital Research Foundation Parkinson's team. Angela is a highly experienced nurse with a strong background in neurology and stroke care. She holds a Bachelor of Nursing, a graduate diploma in nursing science, and has recently completed a graduate certificate in positive behaviour support. She is currently working as a Parkinson's specialist nurse with the Hospital Research Foundation, where she takes a client-centred and holistic approach to care. Angela works closely with individuals and their families to develop personalised plans that support both the physical and emotional well-being, empowering clients to take an active role in managing their health. With many years of experience in hospital-based stroke and neurology settings, Angela brings deep clinical knowledge, compassion, and a strong commitment to education and empowerment in everything she does. She is here to speak to us today about the Living Well with Parkinson's program. Please join me in welcoming Angela.
Thank you for that introduction. Okay, I thought I'd discuss this first slide. A lot of people have heard the Hospital Research Foundation Group, and when they hear that name, they think of the home lottery. And we are employed, that is the same organisation that I work for, and they do wonderful work in that space as a charity organisation. But what a lot of people don't realise is that there's the Client Services division, and we provide services for people living with Parkinson's and also stroke. And I'm here today to talk about living well with Parkinson's disease, so I'll get started now. Okay, so some people may have seen this slide before. It's called the Parkinson's iceberg. So as you can see on the top, there's the tip of the iceberg, and it's often what people can see when they think of Parkinson's disease. So rigidity or being stiff, a tremor, akinesia or bradykinesia, which is when people slow down or they freeze, and postural disturbance, which is in reference to balance. What people don't see is the bottom part of the iceberg, and that's a constellation of symptoms, things like constipation, swallowing difficulties, anxiety, difficulties with reflux, all sorts of other problems. So what we know is that Parkinson's disease actually impacts everyone differently. And living well is a really important concept with people living with Parkinson's disease, and as a nurse I really keep that at the forefront of my mind whenever I'm meeting with a person living with Parkinson's. Okay, so what does it mean to live well with Parkinson's disease? And even when I started thinking about this, so many different things came to mind. So I sort of broke it down into three key elements. And I think as a nurse, when I have a one-on-one appointment, a lot of people sort of a little bit hesitant when they're coming in. They think, well, what will this nurse talk to me about? What's her role? Because we're not in the traditional, doing your blood pressure, wound care, that sort of care we're providing. We're much more of a consultancy service, and we're really there to empower individuals to live well. So today I thought I would go through some practical examples just to give you a bit of an idea of the things that as an individual someone with Parkinson's can do to live well, but also how we support them to achieve those goals as well. So as I said, key elements, so lifestyle factors, and I'm going to give you a bit of an example here. So living well with Parkinson's often means engaging in some exercise, hydrating well, so drinking enough water, eating well, sleeping well. Also things like managing your treatment, so medication often for Parkinson's disease, and also getting some information and support about emotional and mental health and wellbeing in general. So I'll go through some examples now about some of the things that I would typically discuss with someone in an appointment. Now these are three examples I've picked, and they're things that I discuss most commonly probably. But as that iceberg displayed, everyone has a different experience of Parkinson's disease, and so we will actually tailor our appointments really on what they want to address. It's about that person and what's most important to them. So I'll get started with some practical examples now. So medications. So if for someone living with Parkinson's disease, medications becomes vitally important. So Parkinson's disease, as Lyndsey went through, is caused by lack of dopamine, and dopamine is topped up or replaced through medications to a certain extent. So what we would talk to someone about living with Parkinson's would be take your medications on time every time, and it's really about getting good habits up and making sure there's not a break in treatment. Medications are best absorbed on an empty stomach, and some people aren't given that information when they're first prescribed their medications, and it's really important to get the best absorption. when you're out and about, and we really encourage people to access the community, taking a dose if it's due, taking it with you at that time is really important. Looking at medication dispensers, and a lot of people may have seen like a traditional Webster pack, but there's lots of different options on the market, and that might be something that I go through with someone as well. And manage side effects as required. So a lot of people with Parkinson's disease, the medications used to treat the disease itself do come with a significant side effect profile. Now, not every person will experience a side effect, but we like to talk through and see if we can address any of those side effects and mitigate them. And if not, this is something that we can help empower someone to talk to their specialist about. So what help is out there? Well, coming and seeing someone like me as a Parkinson's specialist nurse, I'm not the only one. There's 6 of us in the office. Also encouraging people to speak to their local pharmacists or their neurologist. So they're the prescriber of their medication, okay? And we can help empower you to have some of those conversations and also sort of work out what's going on with your medications and synthesise that information so that when you have that conversation with your specialist, you really know what you want to say and get through, get that information exchange working optimally. Sometimes I'll do a medication timetable with someone. Some of our clients might have medications twice a day. Other people will have them 2 hourly. And if you want to have them on an empty stomach, it doesn't leave much time around in which for you to eat your meals. So we will sort of work out a bit of a timetable for that person. Some people say to me, they might say, well, I'm fine with my morning dose, but I get carried away in the day and I keep forgetting my lunchtime dose, and then they get some recurrence of their symptoms. So we'll talk about strategies to address that. Also, some people will recommend for a home medicines review. Now, I'm not sure if everyone's heard of a home medicines review, but it's a government initiative in which a pharmacist can visit your home to help you understand medications and make recommendations to health practitioners if required. So some of my clients are on really complex medications. They might have lots of what we call comorbidities, so other health conditions. Some people might be taking lots of herbal medicines or over-the-counter, different types of medications, remedies. We're seeing a lot more growth in that space. People can order certain medications online. While I'm a specialist nurse in Parkinson's, I obviously don't know the interactions and ins and outs of all these different sort of online medications. So I will look at someone's medication regime, and if I think that they need a home medicines review, then that's something we can support them to action. The other thing I'd like to point out there, we've got, and these are on our table today out in the foyer, so we've got something called Preparing for Your Specialist brochure. So a lot of our clients will see a specialist neurologist or geriatrician, and when they go to their appointments, it's really important they're able to identify any trends in their symptoms, because medication regimes for people living with Parkinson's need to be individually tailored, okay? And the only way your specialist is going to know what's going on with you is if you tell them. And unfortunately, when you see them, sometimes you're only in the appointment for 15, 20 minutes. And so it's really important the information exchange is really good. So we've developed a little bit of a brochure to help you become prepared about what information you want to share with your specialist. And it has a few prompts about some of the things that perhaps you didn't realise were related to your Parkinson's disease and could represent a need for change in medication. So if you haven't, if you're living with Parkinson's disease, please come over to our table and I can show you the brochure myself today. Okay, another one of the symptoms that we frequently discuss and support people with in the community is bladder dysfunction or continence. So what can an individual do to live well and address this symptom? So some people, as part of their Parkinson's disease, will experience increased frequency, urgency, or nocturia. So nocturia is when people pass urine overnight more frequently than they would otherwise expect. So firstly is to educate yourself on Parkinson's disease and the impact to your continence and bladder. So one of the things that I talk to, probably if I had $1 for every time I spoke to someone about hydration, I'd be rolling in it, literally. Hydration is so important. Drinking enough water. 6 to 8 glasses of water really is the minimum. And we talk to people about, really timing when they're drinking as well. So we don't want you to have 6 to 8 glasses just before bed, but we really want you to have them in the early parts of the day to make sure that you're well hydrated. People sort of have this thing where they think, well, I'll drink less, I'll make less urine. And that is true to a certain extent, but often people will go to the toilet more frequently if the urine in their blood is very concentrated. So what else can someone do? They can avoid bladder irritants, caffeine, chocolate, alcohol, soft drinks, some of the fun stuff, obviously. Does that mean you have to stop and never have a coffee again? No. But if you're experiencing bladder symptoms, that might be one of the symptoms that you want to address as an individual. Again, this is about empowering the person to be aware of these things, but also for them to make informed decisions, okay? Constipation. So constipation impacts the bladder massively. So we really do a lot of work in this area. So we encourage people to manage their bowels. And sometimes people with Parkinson's, even if they're eating the perfect high fibre diet, drinking lots of water, regularly moving, they can still need some support with medications to address their constipation. So that's definitely something that we talk to people about quite regularly. And then some of the practical factors. So if you're someone that is experiencing urgency, which is very common, avoiding clothes with lots of buttons or tricky zips can be one of the strategies that you implement, just to give yourself a little bit more time in the toilet. And also seeking some advice, because there may be some equipment or products that can help you. So again, there's strategies that someone could implement themselves, and now I'll talk about some of the things that we can help with. So what help can you access? Education again. Seeing us as a Parkinson's nurse, we can give you some basic continence and bladder education. We also have one of our nurses who is running a continence clinic for people to get some personalised advice, and she'll do a sort of a continence assessment and plan for that person as an individual. Now, sometimes I always say to people, have you mentioned it to your GP? Because there's a bit of an assumption sometimes when someone's living with Parkinson's that any symptom that they may have may be related to their Parkinson's, and therefore they've just got to live with it. But that's not the truth. Sometimes people with Parkinson's have other illnesses, and sometimes they can be treated, for example, like a urinary tract infection. So we don't want people to discount other things and just make an assumption that it's their Parkinson's disease. Alternatively, sometimes people would benefit from a specialist review, like a urologist, to really investigate the cause of their bladder dysfunction, and we don't, again, want people to put those types of discussions and referrals off. There are physiotherapists that specialise in pelvic floor management, and that's for females and males, both of them. There's the National Continence Helpline, so we might give you some information. There's a 1-800, which is a free call number, to see if you can get some personal advice there. There's different continence products, and we can show people samples and go through things. Some are disposable, some are rewashable continence underwear. Some people, there was a big market for them in like period underwear more recently, and now they've expanded to a continence range, and a lot of our clients are utilising those products. I don't know if anyone's heard of the Continence Aid Payment Scheme. So for people living with Parkinson's, and there's a whole big eligibility criteria of lots of other diseases and conditions, they can be eligible for the CAPS, the Continence Aid Payment Scheme, which is just under $700 annually paid into their bank account to support them for the purchase of continence products. And that's something that the nurses are able to help you complete that application. And finally, I'd never heard of this either, the National Public Toilet Map app. So there's an app on your phone which shows you where all the public toilets are. So if you are someone who maybe is experiencing urgency, or someone like myself who travels regionally and jiggled 3 hours driving somewhere and then busting for the toilet when I get there, there's an app on your phone that you can get on your phone that you can, it has all the public toilets listed, and this again is a government initiative, so it's kept up to date. So that's just that's a bit of an example of some of the things that we might be able to go through, and I've just got one more because I think this is really important as well. So emotional well-being. So how does someone live well and focus on emotional well-being with a neurodegenerative disease like Parkinson's? So what we know about the disease is that it can impact mood and cause low mood, and also cause something called apathy, all right, and reduce motivation. So it's really important, and we often discuss this, about staying connected with friends or family. We know exercise can have a great impact on mood, and I'll talk a little bit more about that in the coming slides. Managing stress. So sometimes it's about eliminating stress, and or where possible, reducing it and developing strategies to manage your stress. So for everyone, that might be something different. But I often say to people, if there's a big driver of stress, can that be addressed? Can we look at modifying that? Can we look at eliminating that? Things like management strategies might include meditation, going for a walk. Again, all going to be individualised. We really encourage people to engage in community groups or activities that you enjoy. And we actually provide some of those options. So I'll discuss that in more detail. And also to discuss your mood changes with your GP as well, okay? Because there could be, again, something else driving your mood. So what can we do from a nursing perspective? Well, at the Hospital Research Foundation, we do have counselling services. Renee's here, our counsellor today. So she'll be at the table later. We also provide art therapy. Again, we reiterate, speak to your GP, exploring treatment options, whether that be a mental health treatment plan, medications, whatever it is that you need as an individual. There are mental health supports or crisis supports available, and we will discuss that with a person individually and as required. We can talk to people about increasing your community engagement, so attending a support group, and we have loads of support groups, so I'll talk to you about them as well. We might complete a companion card application with someone. So I'm not sure if people know what a companion card application is, but if a person's living with disability and they need help at a venue, you can complete a companion card application, which the card name goes in the name of the individual with a disability. And a lot of venues now are having, or events, if you think the Fringe and stage shows, you can select to have a companion present, and their ticket to a ticketed event is often free. So that's a really worthwhile initiative that can get people attending more events. And also I think it's important to acknowledge family and carer support. We would refer people to Carers SA, and I know they're here today. But we can also provide support about experience or education for people and their family and carers as well. So that's something else we can do to help. Okay, so I thought I would talk now a little bit about the Hospital Research Foundation Parkinson's and some of the services that we provide. So I think it's really important when you consider living well is to really develop a bit of a team of people who are supporters, whether that be health professionals, great families, good GP, friends, unpaid carers, people of the like, other people with lived experience. It's really important about creating your team, people who care about you and want to help you along in your journey. So what services do we provide as an organisation? People like me will see people one-on-one, so Parkinson's nurse specialists, and as I said, there are 6 of us. We provide occupational therapy. We have a wellbeing team, counsellor, social worker and art therapist. And we also provide exercise physiology at our Brain and Body Fitness Studio, which has recently relocated to Woodville. So I'll go on a little bit more and talk about what sort of services those groups provide. So Parkinson's nurse specialists, so we're actually a free service. We're employed as a part of a government grant. We provide one-on-one appointments, or we will do group education in some settings. We actually go regionally. So when you hit the regions, we often will do group education in that setting just to maximise the amount of people we can see. Our focus is living well, managing new and existing symptoms, education. We also will help people navigating my aged care and NDIS to a certain extent, which is really good because we can see people before they've got approvals in place. We don't need to act, because we're a free service, we don't need you to wait to have an assessment to get onto a scheme before you come and see us. We can see you before that. We have what's called an open referral policy, which basically means you can be referred from anywhere. You can ring us up and self-refer. You can give our number to a family member, a friend, an occupational therapist, a doctor. We will take the referral from anywhere, provided the person involved living with Parkinson's is keen to, has consented and is keen to see us. So yeah, that's basically what an open referral means. Okay, occupational therapists. A lot of people might be familiar with this service. We've got 2 occupational therapists who are really experienced with working with people with Parkinson's disease, stroke and other neurological conditions. So they could do things like equipment prescription with regards to walking frames, assistive technology prescription, home modifications, all the NDIS report writing, etc., and education. They are a paid service. We are a Commonwealth Home Support or CHISP provider as well, and we're also an NDIS provider. We have a wellbeing team, so counsellor, social worker, and we're currently recruiting to that role. And we have 2 what we call client service coordinators. One who helps us onboard people, so when people are new to our organisation, we have a bit of paperwork, consent forms, details forms, so we know who we're going to be providing care for. And we have another client services coordinator who works at our various support groups, and we have a lot of support groups, so I'll talk a bit about them. We also are very fortunate to have an art therapist. So she provides 6 free sessions to people living with Parkinson's or stroke survivors. And what that basically means is therapy is the main service she's providing, but she uses art mediums for people to express their emotions. So it's a wonderful service. So support groups. This is our list of support groups. So as you can see, they're fairly extensive. We've got some that are by region, so North East, Brighton, Western, Onkaparinga and Adelaide Hills. And then we also provide specialist support groups, so for people with certain therapies like duodopa or deep brain stimulation, but also we cater for people who have young onset Parkinson's, and we have a men's, and we now have a hybrid group for online, for people who want to get online as well. We have several recreational groups. So we have an art group that meet weekly on a Wednesday. We have a photography group, a singing group. So for people with Parkinson's, they often experience changes to their voice. They can get what's called hypophonia, where they can sort of get a much softer voice and it can become a bit husky, and singing's really a great therapy for that. We also have a group called Brain Boost, which can really get the brain thinking. They play games, riddles, all these sorts of things to try and challenge one another and have some fun at the same time. Shout out to our brain and body fitness studios. So we have this is just recently relocating to Woodville, 57 Woodville Road, and they also provide home visits as part of their BBF Plus program. And it's a group of exercise physiologists who have specific knowledge working with people with Parkinson's, stroke and other neurological and chronic disease in general, really. Exercise is so important. Besides for medications, it's probably the next most important treatment modality that we recommend people with Parkinson's to try out. So yeah, we really encourage people to get involved in exercise. And what's great about Brain and Body Fitness Studios, it's all tailored to the individuals, so they can have people of all different fitness levels, and they can tailor whether, you know, someone's been recently diagnosed and you know, perhaps relatively fit, to someone like myself who's pretty unfit. So this is some of the a bit more service information here. So BBFF is led by a team of exercise physiologists, so not your typical PTs. So they've done a university degree and they're quite experienced. You can pay a weekly fee, get unlimited access. They'll do one-to-one individual assessments and 12 weekly reviews, which really helps people track their progress from an exercise perspective. Okay, so again, we're part of the Hospital Research Foundation, and if you need any services, please come to us. We're available. We want to help you, and yeah, looking forward to seeing any of you at our table out there. So, thank you.
So we don't have any time for questions for Angela at the moment, but she will be available in the foyer to ask away. So we'll be getting on with the next presentation.
Thanks so much, Angela, for highlighting the incredible program of supports available to people living with Parkinson's. I'd like to now welcome Liz Withall from Dementia Australia. Liz is a Community Development Officer with a strong allied health background, having graduated from Flinders University. She's deeply passionate about supporting people living with dementia and their families to stay connected, engaged, and empowered. Known for her integrity, dedication, and collaborative approach, Liz works tirelessly to raise the voices of those who are often marginalised and is playing a key role in building dementia-friendly communities across South Australia. Today, Liz will begin by sharing the important work she's doing to help create communities that are respectful, inclusive, and supportive for people living with dementia. These dementia-friendly spaces are essential in reducing social isolation and ensuring individuals remain active and valued members of society. Following her presentation, she'll then be joined by two dementia advocates who will share their powerful personal experience of living with dementia. Please join me in welcoming Liz.
Good afternoon, everyone. It's lovely to see so many people here. It's an absolute pleasure to be here today to talk to you about dementia-friendly communities and to introduce you to two brilliant dementia advocates, Anne Peach and Anthony Pollock, who will be sharing their stories later in this session. Right, let's work this. There we go. All right, we've been sitting for a while. We've had some morning tea, and I think we need to have a bit of an interactive game. So I'd like to know how much we know about dementia. I'm going to do a bit of a true or false with you. So thumbs up means you think it's true. Thumbs down, you think it's false. Okay? And it's meant to be a bit lighthearted and a bit of fun, and we'll go through the answers, so don't feel like it's a test. So, true or false, dementia is a normal part of ageing. It's actually false. Dementia can happen to anybody, but it is much more common after the age of 65. Next one. Memory loss always means dementia. We've got a very clever group today. That's actually false. So whilst memory loss can be a symptom of dementia, it can also be caused by lots of other things like stress, fatigue, depression, side effects of medications, or even vitamin deficiencies. It's important to see your doctor if you are experiencing any changes in your memory or thinking, as they can do proper detailed assessments to try and address some of these issues or send you on for further testing. And it's really important that early diagnosis means that there's more potential options and potential treatments to slow the progression of dementia. And also it's important to note that there are different types of dementia, some of which don't result in changes in memory initially. They happen further down the track. Next one, a family member has dementia, so I will get it too. Yeah, great. So that is actually false. Having a family member can increase your risk of dementia slightly, but it doesn't mean you'll definitely get it too. Most cases of dementia are not directly inherited, and in fact, lifestyle factors like staying physically active, eating well, and keeping your brain and social life active can really help to lower your risk. Again, speak to your GP if you're worried. They can help you get more of an understanding of your personal risk and what you can do to stay healthy
I'd also like to highlight the National Dementia Helpline number, which is a 1800 100 500 number that's available 24/7, and you can ask them any questions about dementia. And it's also a referral service. So if yourself or a loved one needed to tap into some of the services and supports that we offer at Dementia Australia, this is something that you can do. Dementia is contagious. I'm glad there's a few giggles, because this is a really weird myth. That's false. Dementia is caused by physical disorders of the brain, so you cannot catch dementia from other people as you would a cold. Only older people get dementia. Good. Excellent. That is false. Dementia can happen to anybody, but it is more common after the age of 65. And in fact, data suggests that there are 29,000 Australians living with dementia that are under the age of 65. And sadly, we know there are also childhood dementias, and many of these are caused by genetic mutations. Next one. I can reduce my risk of developing dementia. Thanks, Lyndsey, for spoiling this one for us. No, only joking. No, that's great. This is true. There are many things that we can do to reduce our risk of dementia. Things like eating a healthy diet, including plenty of fruit and vegetables, unsaturated oils, lean meats, legumes, dairy and alternatives. Also regular exercise. That's not to say go and run a marathon if that's not your thing. Gentle walking, works just as well. Also social connection, again this was mentioned before, it's so important. We're social creatures, we need to be connecting with one another, which is why it's so nice to see so much conversation happening today. Also, we want to mentally challenge ourselves. So I'm setting a challenge for you tonight. I'd like you to try and brush your teeth with your non-dominant hand. It's harder than you think. But these sorts of things can really help to strengthen the neural pathways in our brain. Also, if you're interested, we have an app called the Brain Track app, which was developed with various researchers, and it has got different games that you can download on your phone which will work different parts of your brain. So it's meant to be tricky. I find it really tricky, but it's good fun. Also making sure you're getting regular health checks to keep your blood pressure and cholesterol under wraps, not smoking as well, and also reducing the amount of alcohol that you're having. It's also important to say that, like cancer, people who have been following these healthy lifestyle habits sometimes do go on to develop dementia, and it's really important to stress that it's not their fault. There are lots of different things that can cause dementia, and that's something that the researchers are really working hard to discover. So, last one for you. People living with dementia can live a meaningful life. Yes. Excellent. Absolutely they can. People living with dementia can continue to live a meaningful life doing the things that they love with a bit of support from those around them, including the community, and this is something we'll be focusing on today. So I thought we would just quickly summarise dementia. So dementia is the umbrella term to describe a set of symptoms caused by brain disease. So it's not one specific disease. Instead, it's a broad term that covers the effects on people of a number of different medical conditions. Sadly, it's progressive, and currently there is no cure. Signs of dementia include gradual changes to thinking that impact on a person's ability to undertake daily tasks. No two people living with dementia are affected in exactly the same way, and dementia is not a normal part of ageing, however, is more common over the age of 65. I won't labour too long on this, but there are actually over 150 different types of dementia. These are 4 of the most common types of dementia, so Alzheimer's disease, which makes up the majority of dementia diagnoses, which commonly affects memory. There's also vascular dementia, which can be caused by reduced blood flow to the brain, and symptoms can include problems with planning, thinking, and movement. There's Lewy body disease, which is linked to abnormal protein deposits in the brain and can cause visual hallucinations, sleep disturbance, and movement problems, similar to Parkinson's. And lastly, frontotemporal dementia, which affects the front and side parts of the brain, and it can cause changes in personality, behaviour, language, and is more common in people under the age of 65. These are some of the symptoms of dementia that can include changes to things like memory, especially short-term memory, judgment, so making sound decisions, spatial orientation, so knowing where you are in relation to something else, language like word finding, planning, knowing the order to do things in, comprehension, so being able to understand tasks, and mood and personality may become, people may become apathetic about activities they were previously interested in. So why is dementia such an important issue? Well, the numbers don't lie. Every 3 seconds, someone in the world develops dementia. And currently in Australia, there are over 433,300 people living with dementia, and there's another 1.7 million people involved in their care. It's estimated by 2054, without a significant medical breakthrough, there will be over 800,000 people living with dementia. The reality is we will all have some connection to dementia. It could be a neighbour, a friend, a colleague, family member, or even ourselves living with dementia. Dementia is a community issue. We know that the majority of people living with dementia are living within the community, not within residential care facilities. So until there is a cure, we must provide care and support for people living with dementia and their families. So what is a dementia-friendly community, I hear you ask? A dementia-friendly community is a place where people living with dementia can live a life of purpose, meaning and value. People living with dementia are included and can make their own choices. The physical changes that are happening to people's brains means that it's really up to us as a community to help create a supportive and inclusive environment. So what do dementia-friendly communities look like? Well, each dementia-friendly community will look different, but may include council services that are accessible for and inclusive of people living with dementia. Ideally, dementia should be included as a disability in disability access and inclusion plans to embed this into their policies and planning. And it's really heartening to see that there are a lot of councils that are coming on board and making positive changes. One you may have seen in social media recently was the Tumby Bay Council, where in response to a person living with dementia and their family who identified that the toilets were really tricky to find in the public toilets, they enhanced signage. So now they're really clear and easy to see, which is a simple change, but not only does it benefit people living with dementia, but the community as a whole. Also, businesses that provide accessible services. So, for example, a cafe where staff are aware, menus are clear, there's good signage, and people are also responsive to patrons' requests for quiet times and quiet areas. Another great example of enhancing spaces. I was at a venue recently, I won't name and shame, but the only indication for men's and women's toilets, there were pearls and gloves, and a top hat and a cane. That was the only way to indicate that they were toilets, presumably men's and women's. That's not very enabling and helpful for anyone, really. So it's the little things that can change, and especially for people living with dementia, having a symbol, whether it be the toilet or the actual male or female symbol, as well as the word male or female and toilets, really helps in that space. Also, clubs that are aware of dementia and support people living with dementia to remain involved are really important, and it's great to see that there are many clubs around South Australia doing different things to support people to remain engaged. So, for example, there is a golf club in the Adelaide Hills that is actually having a dementia-friendly golf day in line with Dementia Action Week, which is the 15th to the 21st of September, and they have got a group of volunteers who have an understanding and awareness of dementia and are supporting people living with dementia to play a social round of golf, and then good old country hospitality. They're going to have morning tea later in the clubhouse with, you know, all the homemade beautiful snacks, which is lovely. Also giving people opportunities to volunteer. So, for example, a choir that is in the Victor Harbour area, there is a gentleman living with dementia who's actually one of the co-conductors of the choir, which is brilliant. Also, a local dementia cafe where people living with dementia are assisting in making tea and coffee. And there's also a museum in South Australia where a person living with dementia is a regular volunteer, which is brilliant and such a great demonstration of a dementia-friendly community. So what are the benefits of a dementia-friendly community? Well, there's many benefits. Really, that it promotes inclusion, and this inclusion means people feel more confident to get out and connect and continue to do the things that they want to do. And just as Robert Gordon said earlier, we all have a right to have fun, and that's exactly what it's all about. And we know that supporting this connection with people, it can actually slow the rate of progression of dementia because social connection is just so important for the brain. It also encourages independence, so being able to navigate your way around spaces. If the signage is clear and the environment is enabling, then people are able to do that. Also, showing understanding, such as appreciating that people may need a bit of further time and support to participate. And I think that's where things like the sunflower lanyard, it's great to see that that's getting more publicity and recognition. So that's for hidden disabilities, and it's fantastic to see that the airport and local shopping centres are getting on board with that. You can simply be wearing one of the lanyards and people will take a bit more time and support, which is brilliant to see. Also, environments can be really sensitive to sensory needs, which is fantastic. As we know, dementia is caused by physical disorders of the brain, which means that brains are working really hard to make sense of the environment around them. So things like sound, smell, sight can be impacted. So environments that are more sensitive to this, that are quieter, with good lighting and clear colour contrast, for example, can help for people living with dementia to feel more comfortable. So how can you be part of a dementia-friendly community? Well, firstly, learn more about dementia. Dementia Friendly Communities has a program called Dementia Friends. It's free, it's available on our website. I have lots more of these cards on our table. In addition to brushing your teeth with your non-dominant hand tonight, I also challenge you to take a Dementia Friends card and give it to one other person to raise some awareness of dementia. So to be a dementia friend, you watch some videos which highlight what dementia is. It also includes people living with dementia talking about how it impacts on them and the things that we can be doing as a community to be more supportive. I'd also encourage you to dispel some myths. So dementia is a topic that a lot of people are scared of, and I think we need to address this. We need to be talking about it. So yeah, try and clear up some of the misinformation out there. Also encouraging local businesses and clubs to get involved by connecting with people living with dementia. Simple feedback from people living with dementia and their families for how spaces could be more accessible can make a huge difference. Also, the Dementia Friendly Communities program has a recognition program where businesses and organisations can show that they are connecting with people living with dementia and making plans and steps and positive changes to better support people living with dementia, and they can be recognised for this too. Also, you might like to consider joining or starting a local action group, which includes people living with dementia working together collectively with local businesses, service providers, local service clubs, and others interested in the community to make a positive impact. Also, we have Dementia Action Week, which is on the 15th to the 21st of September. It's Dementia Australia's national week, which aims to put dementia in the spotlight. This Dementia Action Week, we're challenging everyone in the community to reach out and reconnect with somebody impacted by dementia, and that's because nobody can do it alone, and that is the theme for this year. So that's a little postcard for the event. On the Dementia Australia website, there will be a whole range of free resources, including printable posters and communication cards that you can use to support your activities. So, now it is my absolute pleasure to introduce you to two wonderful people, Anne Peach and Anthony Pollock. Anne is the chair of the Dementia Australia Advisory Committee, and Anthony is one of the members, is also one of the members that you can see above. So this is the Dementia Australia Advisory Committee. The Dementia Australia Advisory Committee provides a national platform for people living with dementia to advocate alongside Dementia Australia on matters important to them. As a formal group, the committee provides strategic advice to Dementia Australia and other stakeholders on shaping dementia services, programs, policy development and systemic advocacy. Members are active advocates with Dementia Australia and agents for change in their communities. Members contribute their specialist expertise by providing their living experience, knowledge and representing their communities. So we've got the wonderful Anne and Anthony here, and who have generously said that they will provide a bit of information about their own journeys and answer some questions. So, did you want to, we'll pretend we're on a talk show and come over here. Go up there? All right. It's all set to go.
Hi everyone. I'm Anne, obviously, and that's Anthony. We're still very clever. I thought I'd just tell you a little bit about my story about dementia and what's happened to me, because we're all very different. First of all, thanks for having us here today. My background is that I have a degree in nursing administration. I worked in the Health Commission of Victoria as a senior nursing advisor before getting married and moving to Adelaide and quickly having 4 sons, which is a cause of dementia. Unofficially. When I worked here, I coordinated services for and arranged groups for people over 65, helping them to remain socially connected. And some of the group members were living with dementia. And I also started a younger onset dementia group, which we didn't have at that stage. And there was an acquired brain injury group too that we ran. Back in 2012, so it's a long time ago, and I was a lot younger and I was 59, and I started finding things hard to manage at home and work. And organising my day or week became more difficult. At work, I was forgetting how I'd worked out a page of budget from one night to the next morning, so I'd have to redo it all again, and numbers was something I was very good at. It became very frustrating. I'd forget that I'd seen a paper that was being discussed, and I asked, I need a copy of this for discussion. And when I got the paper, I noticed I had all my writing all over it. So I'd been asked to review it, but I'd never seen it before. And at home, I found it more difficult. I couldn't follow recipes. I couldn't do Sudokus or read books or do the fine embroidery that I used to love, or clean the house, which I didn't like, but I'd forget which parts of the floor I'd washed and which parts I hadn't. So some parts got really clean and other parts didn't. I'd forget how to hang out the washing, particularly sheets. I didn't get quite how to fold them and peg them on the same line. And I'd get muddled. And the family was really supportive, and we managed through it. But I had a background knowing about dementia, and so I'd also had a lot to do with South Australia Alzheimer's Association, as it was at the time. And I went to the GP, and I said, these things are happening. Had a great GP. She said, okay, off to the Royal Adelaide Hospital, to the memory clinic. And it didn't take long to get a diagnosis of younger onset dementia, which they thought was younger onset dementia at the time. And they also connected me too, which was a great service at the time, to Dementia Australia, although I did know a lot about them. Living with dementia is different and challenging, but it's interesting and exciting. Now that sounds a bit strange. I know it sounds weird, but being an active dementia advocate's meant that I'm busier now than I've ever been. There's hardly a quiet day. I'm keeping my brain as active as I can. I'm on lots of committees, including Dementia Australia, state and federal government, and lots of university research committees here and overseas. I help assess research applications for grants for Dementia Australia, and I look at them from the point of view of these days. Most grants that Dementia Australia gives, all of them actually, have to have an advocate's involvement, so they're being co-designed, which means that the research that you researchers out there are doing is going to be meaningful, and it's going to actually be carried through and be of use to people living with dementia. It's not just for you to get a tick at the end of it and start another research proposal. I've presented at conferences and in Parliament House here and in Canberra, and I love my advocacy work. I think too that I've been able to relearn things. I know, there's a great debate about whether you can rewire your brain and things, but quite frankly, things take so much longer for me to do, but I spend that extra time doing it. So to write something out takes quite a few days, but I'll get it, and I'll get it right. Well, as far as I'm concerned, it's right. And I'll be happy with what I've done. And I spend a lot of time doing things that challenge me. And I don't beat myself up too much either if I'm wrong, forget things. I forget, short-term memory's not too good. But the thing that really gets me is people say, but you don't look like you've got dementia. I'm not quite sure what you're meant to look like if you've got dementia. Are you meant to be drooling in a chair? Or are you meant to be, who knows? But I have dementia. And I also feel that the inadequacies of non-dementia friendly communities that so many people feel today too. But I just wanted to just tack a few things on to my story. When I was nursing, and this has only come from listening to Lyndsey and people this morning, when I was nursing way back in 1971, you probably don't even know that, but there was a year called that, but there was. And as a little first-year nurse, I was sent out to a rehabilitation centre. And these days, it wouldn't happen. It was an old one of those Nissan tents, sheds with the old corrugated iron, 12 beds down one side, 12 down the other. The first-year nurse, what was your job? Was to shower everybody. You had men and women, and there was no distinction between who you were lying next to. And most people had strokes, and there wasn't much in the way of physio or anything really. And when you're on shower duty, you put on a white apron, a white plastic apron, and gumboots. My feet were too big for the gumboots, so I missed that. And you take the patient from their bed on one of those chairs that you can wheel over toilets, and they'd have a towel over them, terribly discreet. It was awful. And then you'd take them out to a sort of shed that was a bit like a cow shed. And there was a concrete area where the person actually was on the chair and you showered them with a hose. I thought that was about the most demeaning thing I'd ever seen. And I was looking after, most people I said were old. This lady was 40. She had a 2-year-old daughter and she'd had a stroke. She'd been a nun before, and she'd obviously left the order and married, and a totally inappropriate place for a 2-year-old to come and visit a mother. And I thought, well, what can I do with this lady that might make her feel that, I care about her? And I thought, well, she's a nun, I'm a Christian. Christmas carols, she might, at least be at ease if I, So my voice is wonderful, I don't think, but I sang Christmas carols and she joined in. And that was one of the most powerful things that I've ever seen. And it's never left me. And it's not something that today is any different. You all know about it. But back then, nobody had ever thought about it. And I mentioned it to the staff on duty, and they just went, oh, yes. I don't think anything happened after I left the ward, but I continued to sing to her, and we had that lovely time together. Yeah, so things have changed so much, though, and so much in research, too, since I started with Dementia Australia. Also, when I was in the Health Commission in 1985, I looked up their annual report once, and the only mention it had to dementia or anything like that was it had a paragraph on demented. So we are coming a long way, but there's a long way to go too. But I just add that in because, you know, we think we're achieving a lot and it's taking so long, but it's not. Things are really happening, and it's just so wonderful to have so many committed people. Anyway, that's far too long for me to have talked, but I thought I'd just share those extra things with you. And I'll hand over to Anthony. Thank you very much.
Hi. Come on, make me feel good. Hey, hi, Anthony. How about make me feel really special and make it louder and say, hi, Anthony. Hi, and don't forget my friends here, Anne. Oh, come on. And Liz. Okay. And let me introduce you to something. This guy. Anthony the Wall Pollock, that's me. And I have dementia. I was diagnosed in 2020 with younger onset dementia. And it changed my life, and my life has never been fuller or better like Anne's. I am so busy. 5 years ago, if I ever told me that I would be standing up in front of you talking, I would run a mile. I wouldn't talk to 2 people on a stage, never mind 200. I'll tell you about my nickname shortly. When I was diagnosed, I was working full-time, managing service stations. After my diagnosis, which was a complete shock to me, I went to a GP, sent me to a geriatrician, sent me to a neuropsychologist, and came back with a diagnosis. So I was totally blown away, never expected anything. Well, a year and a half later, I had to give up work, and then I started working with Dementia Australia. Since then, I've become an advocate, a peer-to-peer leader, a podcaster, hold a moment. I'm a star of my own short film, and I'm a dementia advocate, and I started a Dementia Care Alliance in Gawler just recently, and we're getting that up and going to get carers, advocates and their families together so that they've got somewhere to go, people to talk to, and we can refer them to whatever services that we can find that they need. So it's a bit about my background. I'm not from Adelaide. I spent the last 14 years before I moved to Adelaide in Queensland. I moved to Adelaide about 18 months ago because when I was diagnosed, I was advised to take up some physical exercise, socialize, because I was quite an introvert then. And I went on Google and researched exercise for people over 60. And I found a sport called walking football, walking soccer. Not many of you would have heard about it, but it was started over in England, and it was started for people over 50, old footballers who couldn't run anymore, just to get them to play the beautiful game. And it's taken hold worldwide. So I took it up, not played soccer since I was at school, and I was terrible at it, never got picked in a team. And the first time I went, trying not to run when it's a soccer ball in front of you was very difficult. It's very hard. You try it. And I fell over and grazed my knees. So they said, go on the goals, take a rest, see how the game's played. Well, did that change my life? Because the very first ball that came to me came to the left of the goal, and I dove and I saved it with my hand. And everyone clapped. I thought, wow, that's amazing. I could be good at this. To cut a long story short, I studied it on YouTube, techniques, styles, what to do, how to be better. I ended up representing Brisbane, Queensland, and in 2022 for Australia in the World Championships in Italy, and again this year for the Australian team in the World Championships in Sweden. So this is part of my journey with dementia. It changed my life, and for me it's for the better. What I do now with Dementia Australia is to try and give people hope. Just because you get a diagnosis of dementia, it's not a death sentence. Yes, it will affect your life, but you can do things that help, as we've talked about today. Exercise. Look, exercise done for me. You know, I speak to people around the world now who's walking soccer. I know people from around the world for that. I speak at different venues. I've started the Alliance. I do other things with Dementia Australia, which at different communities are spreading the word. You know, working your brain. I do word puzzles every morning. 5 minutes. That's all it is. 5 minutes every morning. And that helps me. Helps my brain work. It gets me started in the day. So it's only 5 minutes. Over breakfast. Don't Facebook time. Get on a word puzzle. Whatever you like. But it's far better than FaceTime. Or Facebook, I should say. And the long-term benefits, you're not going to find out now because the long-term benefits. You know. Exercise. Doesn't have to be marathons, going to the gym or anything. I go to an exercise physiologist. 1 hour, twice a week. And that's also to do with my sport. Special exercises to help with that. So I'm living very well with dementia. It's not without its challenges, though. I live well because I make the effort. I put the effort in. And it's not easy every day. Not by any means. But I can't do it alone. I have support. And the reason I moved to Adelaide is because when I was in Brisbane, at one of the walking football tournaments, there was a young lady, surprise, surprise, who played the same sport, who came to Brisbane for the same tournament. And we met. I'd injured myself, so I came to watch the game, and we got to talk. And then we got the text. And I was still living in Brisbane, and then we got to fly interstate, back and forth. And then I think, oh, it's expensive. Airfare is expensive. So I decided, bugger it, I'm going to go to Adelaide. Take a chance and see. And now, next year, this lady and I are getting married. And I never thought I would meet anyone again in my life afterwards. Because everyone I would try to date after my diagnosis, and I was always very honest, ran away. Every single one until this young lady. She's very special to me. So there's hope for everybody, is what I'm trying to say. Thank you.
Thank you so much. I know that we're running tight on time, so if anybody's got questions for Anne or Anthony, please come and chat with us at our stall.
Thank you so much, guys. That was incredible. I'm looking forward to asking you questions afterwards. What powerful and incredible stories you both have. Though times can be tough and challenging and not always go to plan, living with hope and embracing and living life is certainly something that I resonate with. And I'm sure many people here do today. Thank you so much, Anne and Anthony, for sharing your journey with us. And now, for the final part of our day and a most anticipated part of the event each year, it's time to award the Embrace Life After Brain Injury Award, which will be presented by Rick Howe, Chief Executive of the Lifetime Support Authority. Please make Rick welcome. Thank you.
Good afternoon, everybody. Hello again for those of you who might have been to these Brain Injury Awareness Week presentations previously. I'm very honoured, obviously, today to be able to announce the winner of the 2025 Embrace Life After Brain Injury Award. I'm also well aware that I'm the only person standing between you and lunch, so I will endeavour to be quick. Through the Lifetime Support Scheme, the LSA plans and funds treatment, care and support for people who've been seriously injured in motor vehicle accidents on South Australian roads. Around 70% of the participants that we deal with are part of our scheme as a result of having incurred a traumatic brain injury, and obviously that's a key connection. Our work with BISA over the years has been really important for those people, and it's interesting today to hear the discussion on how things progress from TBI to potentially neurodegenerative disease and the links that that might have. Thank you to everybody who submitted a nomination and for sharing incredible stories. Unfortunately, without terribly much time, I'm not going to read out the nominations for each of the nominees. There will be a certificate for each of those which has the details of the nomination they received. But I am going to take the time to identify who the nominees were today. So in no particular order, the people nominated were Stefan Stankovic, Nathan Johnston, Banu Paroji, Sandra Lord, Melissa Hartman, who you've heard from today, Terry Wales, Mary Urswell, Ross McDougall, and the final nomination, which is for the winner of the Embrace Life After Brain Injury Award for 2025, is Paul Bovington. And I'd just like to give you a little bit of background on Paul. On the 1st of December 2018, whilst doing a park run, Paul started to feel dizzy, lapsed into unconsciousness, and ultimately suffered a stroke. I knew there was a good reason I don't run very often. He was rushed to the hospital in Adelaide for emergency surgery, put into an induced coma for 3 weeks, trying to stem 2 bleeds that he suffered. And he woke from that coma, totally paralysed on his left side, and had to endure intensive therapy to be able to talk, eat, swallow, let alone to walk. Paul also had part of his skull removed to accommodate the swelling in his brain. Paul eventually made it to Hampstead to continue his rehabilitation, and after some months, the bone fragment was replaced in his skull, and he went back into surgery to have that. Unfortunately, the bone was infected and had to be removed again, and was eventually replaced with an artificial plate and then covered with a skin graft. He continued intensive therapy, progressing from wheelchair to being able to walk independently, never giving up hope that he might be able to run again. He began to return to park runs again, baby steps at first, and continue making progress, going further on each of his outings. Paul continues to amaze everyone with his energy and his devotion to give back to the stroke community. He tirelessly volunteers time visiting various hospitals, rehab centres, offering advice or a kind word to new stroke sufferers. And he also sits on the board of governors for the Hospital Research Foundation for Stroke and is one of the faces of their campaigns. Paul also runs and facilitates 2 stroke survivor groups each month. The aim of the groups is to inspire survivors to be the best they possibly can be and to mentor the participants on their journey. His favourite saying is that you never have to do this alone. On the 6th of April 2025, Paul finally realised his dream and goal to run a marathon. After many short park runs and months of training, he finally reached his goal of completing 105.5 laps of the Bridgeton Athletics Centre 400-metre track in Salisbury, with many family members and amazing support crew. And Paul raised over $5,000 for continued research into stroke. I think that's a particularly inspiring story. Paul continues to lead by example and inspire people every day. Please join me in congratulating Paul. Now, I'm hoping Paul is with us today and making his way up. Indeed. Congratulations, Paul.
Thank you so much. Thank you.
Excellent. I'll just get you to step here and hopefully we'll get a photograph.
Hello. Wow. You know, I think I've been so inspired by, I guess, a lot of the people that walked this path before me. And I remember at the very, very beginning of my journey, looking at some of these people with absolute awe. And I suppose, you know, it's just part of that journey. And I think all of us who have suffered a brain injury of some form, know that it's on us to, I guess, reinvent ourselves and, you know, strive to live the best life we can. And one thing that I tell everybody I talk to is there's life after brain injury, right? And you know, I'm very passionate about that, and I'm just, yeah, this is amazing. So thank you so much.
Congratulations to Paul Bovington for being recognised for his achievement. Let's all give Paul another hand. We have now come to the end of our event for another year. Thanks again to all the sponsors that made today possible. Presenting partner, Lifetime Support Authority. Major sponsor, Livability Care Australia. Gold sponsor, Health Partners. Silver sponsors, Be Remarkable, Nurse Next Door and Medimart. A big thanks also to Heartfelt Support for managing the art installation and to Frank Lynch for capturing the day as our chief photographer. Special thanks to our speakers, Associate Professor Lyndsey Collins-Praino from Adelaide University, Angela Sayers from the Hospital Research Foundation Parkinson's team, Liz Withall from Dementia Australia, and of course our fabulous guests Anne and Anthony. Thank you all so much for allowing me to be your MC today. I've really enjoyed being here, and thank you to all of you for attending and being part of this important awareness week. We invite you to please join us for some light lunch, chat to our exhibitors, and add your contribution to our art installation before heading into the rest of your Monday. See you next year.